Hi there, welcome to my YouTube channel. This is a very short introductory lecture on stereotactic body radiotherapy. Principles and practice of SBRT actually were transferred from SRS or SRT that we were doing for cranial. When we wanted to go for extracranial, the entire principles were transferred to that. The frame-based stereotech patient has been replaced by image guidance here. You cannot fix. Actually, the frames also came up for body long back, but that was not a possible solution. So they went in for image guidance for patient positioning. Some of them argued this renders the term stereotactic misleading, but in my opinion, it is still stereotactic because the only difference is the external XYZ coordinates are now internal XYZ coordinates, either with imaging system or with X-ray imaging or with cone beam CT or with surface imaging system, right? And SBRT is defined as a method of external beam radiotherapy that accurately delivers a high dose of radiation to extracranial target in one or a few treatments, not necessarily in single fraction like SRS. It's a stereotactic radiotherapy, so you can fractionate it also, but it is not fractionated like 25 fractions and all. One of the advantages is you give few large doses. No, that's the idea here. The radiobiological rationale for SBRT is similar to SRS. Delivering a few fractions of large dose is relatively short overall time results in more potent biological effect. They say it is equivalent to having an SRS thing. And the rapid follow-up of dose after the target, like in SRS, is an advantage. The clinical outcomes of SBRT compare very favorably to surgery with minimal adverse effects. Limited number of treatment fractions, so it's very convenient for the patients and potentially more cost-effective treatment compared to other methods. Actually, it started with lung, liver, and spine, but now the SBRT has been extended to various areas. Now they use it for so many things like prostate, renal, mets, and things like that. So well circumscribed tumors with a maximum cross-sectional diameter of 5 centimeter is said to be suitable for SBRT. Some centers have reported they went up to 7 centimeters, but the general guidelines by AAPM is about 5 centimeters. SBRT as a boost for regional nodal irradiation is also a possibility. It's being done. So how do you immobilize and how do you do the simulation and all? The scanning, you can use CT, PET-CT and MR, and the slice thickness should be less than 3 mm. You can't make a large thing because you are treating a very small tumor of 5 centimeter or less. So smaller slice thickness. Immobilization is very important. Whatever best method possible, like vac knee and all should be used to immobilize the patient. I will talk about the motion management also. You can use a free breathing for internal target volume concept or abdominal compression plate. People have used compression plate or a pressure belt or a body fix. Breath hold is also one method which we used in Vellore, which we started in Vellore. And abdominal compression plate has been used by quite a few, but there are some publications which says there is inconsistency in reduction of the respiratory motion. The idea is to reduce the respiratory motion, right, in SBRT. So you try to compress and keep it, but there are some situations where they have found that it is not consistent. So breath hold technique is a voluntary patient expected to hold the breath either at full inspiration or expiration. Patient trained and coached for a few days. In Vellore, when we started, we said 3 days we should first coach the patient on how to have the breath hold. We had a video coaching and it actually increased the cooperation of the patient. Uh, Images were acquired in breath hold position and then also in free breathing position. Plan was done on both, and if breath hold has improved the dosimetry, then the patient was treated in breath hold. When I visited some time back, about 5 6 years ago, Japan, they had a different breath hold method. Like I think I can run the video here. Let's see whether it runs. Sorry, it doesn't run. I'll show you that. See, this is they had a very simple system. They had a pointer, and this is the area the pointer moves, and the patient is asked to hold the pointer in one position. This fulcrum keeps the position of the pointer and also moves depending on the breathing. And this was actually at that time was not connected to the Linac, so somebody had to keep watching it and stop. But later they said it was integrated with the Linac, so if there is any movement beyond a level, so the machine will automatically stop the treatment. And this is a very, you're all familiar with this. This is the real-time RPM device, real-time position monitoring device. And this comes with an external surrogate for position patient breathing motion assessment and positioning, which has got six neon dots. I think the new one that you get has fewer in the TrueBeam. And you can see this box. I will talk about this. There's something which I did, so I'm very curious to tell you about it. The thing is, there are two ways you can have in the CT this RPM device. One is you can mount it on the wall or you mount it on the couch. There is a difference. If you mount it on the couch, when the couch moves for scanning, the RPM device also moves along with that. So the only change is only XY, AP and lateral direction change. There is no superior inferior change in the position. So because the detector system, I mean the infrared detector system is static. So I hope you know this is an infrared camera which detects the reflection from the neon markers and identifies the position. You can see the neon blocks on the TV screen from the camera, infrared camera. So what if you keep it on the wall, then there is the couch movement also will have to be taken into account. So the calibration is much more rugged. So you have to actually calibrate for the change in the superior inferior thing. So there is what you call the 10-point calibration that Varian has suggested. And we made a small jig for it so that every time when you want to calibrate, you keep in these positions and we fix the couch position, we can easily calibrate so that the time taken for calibration is less. So we made this jig and which was quite successful. We could use it for this. And I was very particular that it has to be wall mounted because if you keep mounting on the couch, which many people do, every time you have to remove and refix, or people can touch it and it can get spoiled. When you have it wall mounted, it is there, nobody touches it. So that was the reason I had it wall mounted. So the patient coaching, this is again our own method. We had the video goggle. Video goggle was connected to the computer. So the same screen the patient can also see. So we will tell the patient, look at this blue line and this, make sure that it is within that. The patient can also see this, and patient will keep in that position. When this was started, I was there and I could see that patients were very cooperative on this once they have the video goggles thing. So we also give video goggle during the treatment where the patient will have to hold the breath at the same level. So this really helped in having the breath hold at one particular level during the treatment. The treatment planning, what we used when I was there was fixed beams, not VMAT or anything. We used 3D CRT thing. We used 6 MV. And you are advised to use 6 MV, particularly if it is lung. Other areas you can use 10 MV also. I have seen people using mostly 10 MV. And the dose rate with the double F, we will go up to 600. With triple F, you can go to 14 or 2400. The technique again, as I said, 3D CRT with non-coplanar beam, you have to put multiple non-coplanar beams. Of course, now with VMAT, people achieve the same or a better distribution. So most people use VMAT for SBRT nowadays. Again, choice of energy, I said 6 MV for lung, higher beam energy. The lateral beam penumbra due to lateral electron transport into the medium will be higher. So that's why we say for lung, you should use only lower energy, which is 6 MV. So low density medium such as lung tissue, the effect becomes more significant. And with 6 ME, you don't have any neutron effect. Use of 10 ME for liver and other lesions become very common. Use of high dose rate would shorten the treatment delivery time, and as much as 18 gray could be delivered in one fraction. So this was one of the advantages. And short treatment time would also help in moving organs. So that's another advantage of using higher dose rate. So you can finish the treatment much faster and will reduce the gated treatment time. As I said, the choice of technique 3D conformal, multiple non-covalent 6 or 10 ME for lesions less than 5 centimeter. IMRT 5 or 9 beams. Of course, VMAT you can use single arc preferably because you don't want to do a longer treatment time. So, but some people may do even multiple arcs. So how do you deliver the treatment with the LINAC or chemotherapy or SBRT? But you need to have some tracking system. Some 10 years ago I saw when they were doing SBRT in one of the centers in Australia during a visit. They used cone beam CT. They did a cone beam CT in the beginning, and during the half the treatment they stopped, and then at the end they had that optical reflective markers, not the surface scanning, reflective markers to make sure that the patient doesn't move in between. And they were verifying the after the treatment also they did CBCT and verified whether the position is correct. And if you're using Trobo, you may have go for a MVCT, or tumor tracking will be an option. The dose usually is 41.8 gray in 6 fractions over 2 weeks for liver mets. Single fraction SBRT dose 14 to 26 gray. This is from Heidelberg, a threshold dose of 13 gray in 5 fractions. Lung, there is one study which is initial phase 1 study assessing dose escalation of SBRT. Inoperable lung cancer, 24 gray in 3 fractions. Phase 2 study of 60 to 66 gray in 3 fractions. Because I don't want to go too much clinical into it, I will leave it to the radiation oncologist to do that. I'm not an expert on this. Thank you very much for your patient listening. And if you have any questions, I'll be extremely happy to answer.